All right, so today we're going to cover abdominal procedures in MRI. So you guys know I always start with a little anatomy, cross-sectional anatomy, just kind of review. And also it's important that you guys know this for the registry. So what type of weighting do we have here? And what image plane?
Is coronal.
Okay, coronal, and what type of weighting?
T2.
Good, and how do you know that?
Because you know the CSF, I mean the water, I mean fluid. Yeah, here.
Here?
Uh-huh.
Okay, so yeah, CSF fluid around the spinal cord. This is we can't actually see the spinal cord yet, but we know this is the CSF because here's the vertebral column. And this is a coronal because we're going to A to P. So let's quickly go over some of the pertinent anatomy. So we got the right lung here, A. B, the liver, and this is the dome of the liver right here, so the top of the liver. So we always need to be able to visualize the top of the liver down to below the kidney, because that's kind of the area that we're scanning for abdomen. So always find the top of the liver. C is going to be our spleen. D is our left crux of the diaphragm, and you can see that here. Then you can see the right crux of the diaphragm here. So that's the attachment of that diaphragm. E, you have the adrenal gland above the right kidney. So adrenal glands typically look like little triangles. These are hormone secreting glands. F is our right kidney. G is, what do you think G is right there? You see them on x-ray. You know you have adequate penetration on an abdomen x-ray.
Psoas muscles.
Psoas, good. I is the CSF fluid in the spinal canal, and then J is those gluteal muscles. Those are kind of the attachment of the gluteal muscle. You're like, that seems a little high, but that's the attachment of the gluteal muscles to the iliac crest. And then H, I don't think I went over that. H is the oblique abdominal muscle, right in that love handles area. All right. So what type of slice do we have here, and what is our image weighting?
Axial.
Good, axial.
T2.
And is this T1 or T2?
That's a T2.
T2.
The fluid over there, yeah.
Right. And is this fat set or non-fat set?
Looks like a fat set.
Fat set is dark.
Look at the subcutaneous tissue in the abdomen. All the fat within the organs are dark also. The fat within the bone marrow is dark. So this is a fat set. So A, this is anterior up here, the anterior wall of the abdomen. A is the abdominal muscles. B is the stomach. So sometimes people get confused and think the stomach and the spleen are kind of in the same area, but stomach is more anterior. Spleen is more posterior. So spleen back here, I. Okay, so, and then D is that the liver. And you could say you have the right lobe here, you have the left lobe over here. D is, what do we think D is?
Pancreas?
Not yet. This is actually bowel, and this is the very top of the bowel near the spleen. So this is the splenic flexure of the large bowel. E, that's the portal vein, so the vascular in the liver. F is the abdominal aorta, usually is right next to the vertebral bodies. G is that vertebral body. And this is probably in the T-spine because you can see a rib right here. And then H, spinal canal. I is the spleen over here. All right, and then we have, what do we have? What plane and what type of weighting?
This is T2, axial.
Okay, fat set or not fat set?
No, it's not fat set.
Good. All right, yeah, I'm happy with the responses, but I want to make sure you guys are really getting this. You should be able to look at any image now and determine if it's T1, T2, fat set, not fat set, whether, you know, it's a stir, things like that. Proton density still could be a little tricky, but you should definitely be able to tell if it's T1, T2, and if it's fat saturated or not. All right, so then here on the anterior portion of the abdomen, we have the subcutaneous fat. B would be our abdominal muscles, abdominal rectus muscles. C is that transverse colon, so it's going across. So this is the large bowel here, going across. D, excuse me. D is the superior mesenteric artery. You can see that here. F is the abdominal aorta or the thoracic aorta, depending on where you're at. I think I skipped over E. E is the left adrenal gland, and once again, it kind of looks like a triangle, or if you're a Star Trek fan, it looks like the logo or emblem of Star Trek. G, vertebral body. H, right kidney. I, spinal canal. J, spinal cord. H are those erector spinae muscles. So that's a common registry question, these muscles back here. So rector spinae muscles, and then psoas muscles, you can't see them yet, but they're a little bit more anterior. So don't ever get the psoas and the rector spinae muscles mixed up. The rector spinae are always behind the vertebral body. So is this fat sat or not fat sat? Did I already ask that?
No.
Not fat.
Not fat sat. I think I already did ask that. All right, so then here we have axials, and then we have in and out of phase. So in and out of phase is very useful for determining if you have fatty liver or if you have adrenal adenoma. So you can tell the difference because water and fat in a voxel are in phase with each other, so you don't get that banding artifact on this side. But then where water and fat meet, you get this dark banding where you get a decrease in signal. And this is how we're able to determine this is the out of phase image. So these are images, 2 images acquired with separate TEs. And remember, your TEs are set to image in phase and out of phase because water and fat, they process at different processional frequencies. Sometimes they're in phase, sometimes they're out of phase with each other. And then here we have a T1 fat sat post gadolinium. So you can see the gadolinium in the kidneys. You start to see it light up the spleen and the liver. And then here you have a T2 because the fluid is bright and with fat sat. So just going over the anatomy here, A is the liver, B is the gallbladder, C is the, I would not say tail of the pancreas, it's the head of the pancreas right here, head of the pancreas. D is the tail of the pancreas. So pancreas is one of the hardest organs to find. E is the spleen, pointing over here. F, we have the colon. G, kind of hard to see where G is pointing to, but that's the body of the pancreas. So head, body, tail. H is the abdominal aorta. I, kidney. J, other kidney. All right. So if you are still having trouble on anatomy, a really good site for this is called Mri Master. And you can do abdomen axial, you can do abdomen coronal, abdomen arteries. So this is a great website. You can just flip through your slices and just kind of see all the anatomy. But the hardest structure is typically the pancreas. But this is the pancreas right here. You got the tail of the pancreas, body of the pancreas, and then the head eventually circles around over here. There's the head of the pancreas. So please flip through the axial and your coronals at least to get a better understanding of the anatomy here. Great website for anatomy. Look at all of the different structures that you can flip through all the scans. All right, so back to patient prep. So every site differs on this. I know Emory's not, they don't really care too much about no food or no drink. But the place I worked up in DC, everybody had to be NPO for at least 4 hours, preferred 8 hours, so that you didn't have all that food within the stomach and the large and small intestine, creating sometimes a ghosting artifact because all that peristalsis is going on. Fill out consent form, all that stuff is the same. Most of the time when you're doing abdomen, it's going to be with contrast, and you're going to hook them up to the pile injector because you're doing dynamic imaging. You're imaging during the arterial phase, you're imaging during the venous phase, and you're imaging during what we call a delayed phase. So IV with power injector. Typically these take about 30 minutes, but sometimes depending on if it's an EOVIS study or if they're looking at a certain area of the abdomen, or if it's an abdomen and pelvis combined, these studies can really start to kind of increase in your time, 45 minutes to 60 minutes. It's important to remove all metal, keep still, note the patient's weight for SAR issues, and it's important that you sometimes go over breathing instructions and just kind of have a general game plan and have an idea of how the patient breathes before you get in the room, because they might freak out a little bit once they're in the bore. Maybe have them do a trial run before you get in there and just say, all right, take a breath in, but don't like overexert yourself, just a normal breath in and then release it, so that they have consistent breath holds. That's the key, consistent breath holds, because you want the top of the liver to be at the same spot each time. All right, positioning, most of the time they're going to be supine. You have the luxury of doing these head or feet first. So depending on if they're claustrophobic or not, you can adjust. You're going to give them the headphones because you're going to be doing breathing commands. Don't forget the headphones. You got to tell them when to breathe and when to stop, when to breathe. Positioning, the abdomen coil is going to be, basically the top of the coil is going to be from their armpits, or you could say the nipple line, down to the iliac crest. Put some cushions under the leg for extra comfort. Centering and isocenter laser beam is typically going to be at the xiphoid process of the sternum, or just mid-coil. So wherever you set up the top of the coil at armpits and then down to the iliac crest, anytime you have these little crosshairs, just go mid-coil with your isocenter. Secure tightly to prevent respiratory artifacts. You can decide what to do with the arms. You can either put them above their head or beside them, whatever you want to do. But we know if they're a larger patient, you might not have enough room to put them by their side, so you have to put them above their head. All right, coverage for abdomen scans. So when it comes to coronal, that's pretty simple. We just cover A to P, turn on some oversampling. But axial, we need to get a couple slices above the top of the liver. So we're going to be scanning into the lungs to below the kidneys. So most of the abdomen scans are going to be axials. So it's really important that we get from the top of the liver to below the kidneys. So I put a little note here. It says, make sure to set up axial T1s from breath hold coronals, or T1s. You always want to set a T1 off of a T1. Breath hold off of a breath hold, because you know where the top of the liver is on a breath hold. So if this is my breath hold T1, I know that the liver's not going to go up any higher, so I can put my top of my slices here. But if it's a T2 and it's a non-breath hold and they're free breathing, that top of the liver might vary a little bit, might go up and down just a little bit. There might be a little what I call bouncing of the top of the liver. So I need to maybe put my top slice here a little bit higher, just to make sure that they, as they're freely breathing, that the top of the liver doesn't go above my slices. All right, indications for abdominal MRI, there's millions. We can go on and on for days about all the different types of scans and indications. Most of the time when we're looking for liver disease, hemochromatosis, any type of fatty infiltrate or fatty liver, that's a reason. Lesion metastasis, lesion characterization, So diffusion scans are helpful in that. Clarification of finding from another imaging study. So if they had an X-ray or some kind of, small bowel follow through, or if they had a CT and they saw something, they don't know exactly what it is, that's a reason to send them to MRI. Evaluation of tumor response to treatment, could be chemo or radiation therapy. Congenital abnormalities, iron within the liver, see how much iron is in that liver. Evaluation of vascular patency, so MRA, MRV of the abdominal area, and cirrhosis also. So here's Emory's protocol for abdomen. So here it says routine, this is A1, routine abdomen. So for prep, they say consider arms above the head or towel under armpit for GE systems. And just kind of get those arms out of the way, creating that wraparound artifact. So coverage is going to be from the liver dome. So you put the top of the coil at the nipple line or the armpits to below the kidneys at the iliac crest. And then here are your sequences. And note, this is your breath hold. This is kind of the routine. If the patient is like under sedation and they can't obviously hold their breath, they're unconscious, this is what you would choose right here. So let's not really focus on this. Let's focus on what you normally see every day in clinic, and it's going to be these breath holds. And when it says breath hold, some of them are breath hold, but some of them are free breathing. So you always do your 3-plane localizer to start. You do your coronal T1. It's going to be a vibe for a Siemens, a lava for a GE, and this is a breath hold. All your T1s, take note, breath holds, T1, breath hold. Always make that association, T1, breath hold. T2, a haste, and this is going to be free breathing. And you see here slash breath hold, but most of the T2s are going to be free breathing. Axial T2, you're going to set off this coronal T2. Once again, it's free breathing. Axial 2, fat set, set it off the coronal T2. Or you could just copy it from this one, free breathing. Axial steady state free precession, this is a gradient echo, true FISP. Free breathing, once again. So you have 3 in a row where the patient can just breathe normal. You give them a break. You had them hold their breath that first sequence, give them a break, and then we'll hit them with a couple more breath holds right before we inject contrast. So Dina down at Winship is great about that. She kind of changes her sequences to kind of make it more comfortable for the patient. So kind of just take note of why these technologists are doing the things that they do. So, but I just thought that was a great idea that she does that. And then you can see here, these axial T1, the in and out of phase, in and opposed phase, should be set off of this T1 vibe. So always set a T1 off of a T1. That's why we get the coronals first, so that we can set up the axials. And then here you have the pre-vibe 3D gradient echo T1. Once again, we're going to be set off this coronal T1. Then you inject your contrast. You hook them up to a power injector. You determine how much contrast they're getting depending on their weight. So say if they're 150 pounds, they might get 15 cc's of Prohance. You're going to be injecting at 2 cc's per second. So put that into your power injector, 2 cc's per second. 15 cc's of contrast. And then your saline, you can set that to whatever. I mean, if you're hooked up to a big saline bag, you could do 20 cc's. If you did the little tubes and you only have 10 cc's of saline, just put 10 cc's of saline there. And you can determine if you want to turn the KVO on or keep it off. Everyone's different. KVO, what does that stand for? What does KVO stand for?
Keep vein open.
Good, keep vein open. So basically it's just going to be dripping a little bit of saline into that IV that you started. It keeps the vein open. So when that bolus of contrast, when you inject it, it doesn't really shock the vein, because if you have a little bit of fluid already flowing in there, it's less likely to blow the vein. So keep vein open is just kind of something, some people like to use to kind of prevent a vein from blowing, or from like scaring the patient when that contrast initially goes in. Some techs just don't even like to mess with it, so they don't even turn it on. Personal preference. I like to use the KVO just because I think it's a little bit more comforting for the patient. Okay, so now you're injecting. So your bolus trigger, this is what we call that care bolus, or so you're basically going to find the abdominal aorta. This could be a coronal or a sagittal, and you're going to basically get one thick slice through the abdominal aorta. So as you're scanning in real time with this bolus trigger, you inject, and you'll see that contrast start to fill up the heart. Okay, I need to get ready. You'll see that contrast go into the thoracic aorta and the aortic arch, and then you'll start to see it come down into the abdomen. Boom, I need to start my sequence. And then here, basically, it runs a couple vibes right after it. You get an arterial phase. And don't ever turn off your power injector after you inject. Don't ever just stop the KVO, because that timing of that power injector helps to know when to start the venous phase. So you start that arterial phase right when you see that flash of contrast go into the abdominal aorta. That usually is just an 18-second breath hold, or however long. And then you have to give the patient a couple of seconds to breathe. And then at about a minute to 70 seconds, you start the venous phase. So you start that vibe. And then you got some time before you do the delayed phase, because that happens at about 5 minutes. So they just throw in a couple extra pulse sequences in between. You do an Mrcp, where you find the head of the pancreas and those biliary ducts. And you do a coronal Mrcp. You do an axial diffusion of the liver, and we already talked about what diffusion is good for, liver characterization of lesions. And then after your 2 delayed phase vibes, you do an axial and a coronal. You can just do a coronal 3D Mrcp. So it's just a high resolution visualization of those biliary ducts. So that is just kind of the general protocol that you're going to see at Emory. And post-processing, we always do subtraction images of the arterial, venous, and delayed. And then you always do a MIP of the coronal Mrcp. All right, so let's talk about what those mean. Oh, after we talk about this. So Eovist is what we call a hepatobiliary contrast agent. So that is not going to be eliminated through the kidneys. It's going to be eliminated through the liver and the gallbladder and those biliary ducts. So that contrast is slowly going to drain out of those structures. So that's helpful for when you're looking at the biliary system and the liver specifically. So they'll order an abdomen protocol where you're injecting Eovist compared to ProHands. So you can just see here, since it drains a little bit slower from those structures, usually you want to scan after injection, about 20 minutes post-injection. And then you just want to call the rad and say, hey, are you able to see what you need to see, or do I need to scan again? And sometimes you have to, continuously scan for like an hour sometimes, just because it takes a little bit longer for that contrast to drain through that biliary tree. But just know Eovist is a hepatobiliary contrast agent. It is not going to be eliminated from the kidneys. It's going to be eliminated from the liver and the biliary ducts. All right, so let's talk about these sequences a little bit more. So we don't really need to go over 3-plane localizer. That's just 3 quick gradient echoes in all 3 planes. So just kind of have an idea where the liver is and where the structures are. A vibe, a coronal vibe, and it says Fat Set. It's a T1 breath hold. So what does vibe mean? It's basically just a volume acquisition breath hold examination. So that's what vibe means. And that's an acronym for Siemens. But a vibe on a GE is called a lava. So just know it varies depending on the manufacturer you happen to work with. A T2 coronal haste, and you're like, what is a haste? A haste is a half Fourier acquisition, single shot turbo spin echo.
Oh my God.
That's kind of a mouthful there. But this is the pulse sequence of a haste over here. So you can see that basically you're filling all the lines of K-space in a single shot. So you can see here we're filling all the lines of K-space because the gradients are turning on very rapidly. So this is what we call a free breathing because we're allowed to image while the patient is breathing. So very rapid imaging. Half Fourier, the very beginning, half Fourier just basically means you fill half of K-space. And remember, K-space is symmetrical. So if you fill half K-space, you can just replicate the data from the top and fill in the bottom. So it even speeds it up even more. So then that's a T2. So that's a free breathing. So that's what FB stands for. And then you have your T2 axial based off of your T2 coronal. Your axial steady state free possession, or sometimes you'll see it as a true FISP. That's a T2, so it's a free breathing. Your axial diffusions, your B values are going to be for Emory 220 and 500. So it's just covering the liver. So you don't even need to get below to all the way through the kidneys. You just want to cover the liver. But remember, the B value is not 0. It's slightly above 0 because we want to look at the lesions within the liver and eliminate signal coming from the blood vessels in the liver. You also have a coronal thick and thin sequence visualizing the Mrcp and those biliary ducts. You got your Axial T1 in an opposed phase. That's a breath hold, so you base it off of a breath hold. So sometimes you might see it as called a Dixon because we had a radiologist with the last name Dixon who created this pulse sequence. Your timing contrast bolus trigger, that's your care bolus. That can be done either sagittally or coronal. I see most technologists setting it up in the coronal direction. I think that's probably the best just because you can kind of see the contrast going through the heart before it comes down into the abdominal aorta. And then you got your dynamic imaging. So you have your vibes. You always set one up pre and then basically copy post. So everything that you set up pre, all those parameters and the field of view and the slices and the slice thickness should all be identical to post contrast. And you do an arterial, you do a venous, and a delayed. And then you get a coronal vibe on top of that, a coronal vibe at 5 minutes post-contrast. So here's just kind of a quick reminder of what EOVIST is. It's a hepatobiliary imaging contrast. And the maximum contrast between normal and abnormal tissues usually occurs at 10 to 40 minutes past injection. That's why on this protocol, you saw for the EOVIST protocol, 20 minutes. Because this is an average. So we might be able to see that lesion highlight 20 minutes post-contrast, but it still might not highlight. So even if you do this 20-minute scan, you're not done. Call the rad, make sure they have everything that they need, and then they'll tell you whether or not to get the patient up or not. Anybody do an EOVIST abdomen yet? EOVIST abdomen?
I've seen them at St. Joe's.
Okay. So long scans, right?
Yeah, very long. We had to keep calling the radiologist.
Yeah.
And he's like, 20 more minutes.
And with that, they sometimes play it where they'll get the patient up, they'll do another scan, and in the meantime, and then they'll bring that patient back on the scanner and scan them like 30, 45 minutes later. All right, so here's just some imaging of the abdomen, just kind of get you used to looking at some of the image quality and doing image evaluation of the abdomen. So here is a T2 coronal haste. So you can see the fluid within the biliary tree is bright, so I know it's a T2. It's a coronal. Here's that axial haste, it's a T2. Here's axial haste T2 with like a longer TE, so T2 tissues are going to actually appear higher in signal value. We have a black blood EPI, echoplanar imaging. We don't really do this sequence at Emory. Here's another coronal haste. Okay, here's the MRCP. So you can see the biliary tree here. So we have the right hepatic duct, left hepatic duct, common hepatic duct. This is your cystic duct coming over from the gallbladder. They meet and they form the common bile duct. And then this little thing right here, this is the pancreatic duct leading off to the pancreas, which is over here. So this area right here, this is the small bowel, and you can see the C loop of the duodenum right here, wraps around. This is the ample levator, all that stuff. All right, over here we have T1 in phase. Remember, water and fat are in phase with each other on this one. We know it's a T1 because the CSF fluid is dark, but there is no ringing, black ring around the abdominal anatomy structures. Compared to now, we have the T1 opposed or out of phase image, and you can see that black ring around all these structures. And that black ring, once again, is created because that's the interface of fat and water, and they're out of phase with each other. Unenhanced T1 fat set. So we have not injected contrast yet. Here's the arterial phase. We know this is arterial phase because abdominal aorta is bright with contrast. The renal cortex is bright with contrast. The middle of the kidneys are not enhancing yet. The portal phase or the venous phase, you can start to see the kidneys completely filling with contrast. We have a liver that is brighter than with the arterial phase. And then here's just a T2 fat set. All right, so let's just talk about what out of phase imaging is. It's called the Dixon technique also. This is another suppression technique. So this is a gradient echo pulse sequence, a T1, where you have two separate TEs, one where fat and water are in phase, one where fat and water are out of phase. So we're selecting two TEs. This is great for diagnosing adrenal adenomas, so fat within the adrenal gland or a benign fatty tumor within the adrenal gland. And you can see that here because if you have fat within the adrenal gland, on the in phase, you're going to get this appearance, this kind of signal intensity. But then when you do the opposed phase, look at how dark that structure is now. So we know we have fat within that adrenal gland. So it goes from a bright structure to a dark structure. All right, and then it's also good for looking at fatty liver, microscopic fat within the liver. So on the in phase, the liver is very high in signal intensity. It's like a bright gray. But then on the out of phase, it's very dark. So this helps diagnose a fatty liver. Our MRCP, this is typically our thick or thin T2 haste, coronal oblique. Some people do a true coronal, some people do an RAO, some people do an LAO. It all depends on what they're trying to look at. RAOs used to look at the biliary tree and the pancreatic duct. LAO is to look specifically at the gallbladder and how it attaches to the biliary tree. So this is an RAO because you can see the gallbladder is not really fully in this particular slice. So they're looking more at the biliary ducts and the pancreatic ducts. So this image is associated with this right down here. So this is how you set it up. You find the head of the pancreas, and the biliary tree is kind of going to all converge around the head of the pancreas. And you just angle it appropriately. So the head of the pancreas starts to kind of angle this way, and then the body starts to loop around to the tail. But you're going to angle with the head of the pancreas. Make sure it's high enough so you can see the biliary tree here on your coronal. So you got coverage above the liver all the way down to below the kidneys so that you get a beautiful image of the biliary system so that they can look and see if there's some kind of narrowing of the biliary tree or if there's stones within the biliary ducts. This is kind of like a it's called an MRCP because it's like our ERCP. What's an ERCP in X-ray?
Endo something.
Endoscopic, retrograde,
Cholangio.
and you're looking at the kind of like cholangio and the pancreatic ducts. So this is just the MRI equivalent to an ERCP. So, but obviously less invasive. You don't need to put them under general anesthesia. So make sure you know the anatomy of the biliary tree and the gallbladder and the pancreatic duct and pancreas and small bowel, ample evader. All those things will be on the registry and on my test. All right, and then we do a diffusion of the liver specifically. So all you need to do is cover from the top to the bottom of the liver. And the B values vary depending on the hospital or the department. Typically, you see 1 or 2 or 3 B values. And remember, as you increase your B value, you're making the pulse sequence more sensitive to diffusion. But for the liver, water molecules do not diffuse as freely as in the brain. So you don't have to set the B value as high as like in the brain. So B value of 20, 50, 500, and 800 are sufficient. So we'll be able to see diffusion in the liver, but we'll also be able to characterize lesions in the liver by their ADC values. So remember, we do not want a B value of 0. Sometimes you get it just as a baseline, but you can see here B value of 0, you start to see these blood vessels a little bit too much, and it hides this tumor over here and here. But then we set the B value to 50, and look how now you can see these lesions a little bit easier without those blood vessels in the way. All right, and then the most important scans of a liver, it's this dynamic enhancing images. So dynamic contrast enhanced images, and they're going to be the vibes, the volume, breath hold acquisitions. So it's a 3D T1 volume acquisition. So we know it's T1, CSF fluid is dark. It's a fat setted image because all the subcutaneous tissue is dark. And you do a pre-contrast, and then you do 3 axials post-contrast, arterial, venous, and delayed. Typically it's at 5 minutes, not 3 minutes. You can do it 3 minutes too, but it depends on the site. But at Emory, typically they do it at 5 minutes. And just take a look at what structures are highlighted at each pass or phase. Arterial phase is the first pass, usually 20 to 25 seconds post injection of contrast. Remember, you inject contrast, you have your care bolus on, you're waiting. Usually it takes about 20 seconds to get to that abdominal aorta. Maybe even less, 18 seconds, maybe even less than that, like 16 seconds. So you have to be on your toes, ready to hit, start sequence when you see that contrast start to go down the abdominal aorta. But what's going to appear bright on the arterial phase is the renal cortex. So this is bright on the outer rim of the kidney. The medulla is going to be hypointense, so the middle of the kidney is not going to be bright. The spleen is going to be hyper intense compared to the liver, so it's brighter over here than over here. And it's going to be what we call mottled. So it's going to have little spots where it's bright, but then spots where it's dark. So a mottled appearance. The portal venous phase typically occurs 60 to 70 seconds post-contrast injection. So that's why it's important not to turn off your KVO, because that helps you keep your time. So then this is what it looks like. You have arterial, blood flow is still bright. kidneys are now pretty much iso-intense in terms of the medulla and cortex. The spleen is fully enhancing with contrast, and now the liver is now brighter because you're not starting to get contrast to the liver. And this portal vein right here is filled with contrast compared to it was not before. So then the 3-minute delayed, pretty much everything is now bright with contrast because everything has now had an opportunity to get contrast to it. So everything is enhancing. Let's see if there's anything I need to mention. Okay, so I say here in my notes, most liver cancers are arterial fed, and so they're visualized mostly on the arterial phase. So you guys see this lesion right here. It's hyper intense compared to the rest of the liver, and this is the arterial phase. So this is a malignant lesion in the left lobe of the liver. Hemangiomas are benign lesions that are venous fed, and so those are visualized more on the portal or the delayed phase. And then it says HCC tumors are that wash out fast are going to be dark on your delayed phase. So if they wash out quickly, like a lesion, and if it's dark on the delayed, here it's not, but I'm just kind of, referencing the delayed phase. If it's dark, most likely it's an HCC lesion. And then I also put in the notes what exactly VIBE stands for: volume, interpolated breath hold examination. LAVA stands for liver acquisition with volume acceleration. Thrive is, and that's for Philips scanners. That is T1 high resolution isotropic volume excitation. So you don't need to know what those acronyms stand for, but just know that they are T1 3D acquisitions.
They use just VIBE or LAVA for the just abdomen or the sequence?
No, you'll do it for other areas of the body too, but mostly in the abdomen. But anywhere you might have what we call dynamic imaging. So you could do it in the breast. You could also do it in the chest sometimes. Anywhere where you're seeing the arterial, venous, and delayed phase are typically VIBE.
I think I saw LAVA on the brain too. Maybe I'm wrong.
Sometimes, I mean, I don't know exactly why they would do it for the brain, but if they were looking at the arterial, venous, and delayed, maybe there's some kind of tumor they're trying to rule out. Maybe they do a LAVA or VIBE at the brain. But you can do it anywhere. All right, so here's just another kind of figure to kind of really show you the arterial, the delayed, and then here is even the hepatobiliary phase. Just kind of looking at how the liver is starting to highlight and excrete that contrast. But I think these are a little bit better image quality than the slide before. So you can kind of really see those structures highlighting. When you do these vibes, every vibe, you always subtract the post-contrast from the pre-contrast image, and then you get this subtracted image to better visualize these lesions. So this is what we call an arterial phase here, and you can kind of see these lesions on the periphery of the liver, but you do subtractions, and it helps to even visualize those lesions better. Most of the Siemens scanners will automatically do subtractions. Some of the GE scanners, you have to do those manually. This is the care bolus is kind of typically what it looks like. So here they're doing a coronal care bolus, and you want to position your slice, your thick slice, with your abdominal aorta. So you know your abdominal aorta is anterior to the vertebral bodies. It typically has this general angle to it. So angle appropriately. Find it on the axial. So we know that the abdominal aorta usually sits anterior and to the left of the vertebral body. Find it there and just angle appropriately. So when you start your care bolus sequence, you can really make sure that you see that contrast go down the abdominal aorta. So if you see contrast start to shoot down, that's when you start your pulse sequence. You tell your patient to hold the breath real quick, start your pulse sequence, and go.
Sean, I see the carbolus in the cello too for the pituitary gland.
Yeah.
We made it, tight, like exactly the box like that. Yeah.
Yeah, and I mean, you need dynamic imaging of the pituitary, because remember, the pituitary is one of those glands where the gland actually lights up with contrast, and then the tumors, the micro adenomas, are so small, but they usually take a little bit longer to light up with contrast. So the pituitary gland lights up contrast, the microadenoma does not, and then it slowly does. So you need to see it in real time. You need to see it in arterial, you need to see it in venous and delayed phase. Yes, Shamarva.
Did you get my email?
I did, yes.
Yeah, I took a good bit of the medicine. I'm exhausted. I'm sorry.
Okay.
Yeah, I can't keep my eyes open.
Okay. Well, then you can. This is being recorded, so you can watch it later. Okay.
Thank you.
All right. So then you have special, sometimes sequences and scans that you have to do for these particular body parts. So we'll go over those real quick. Some indications for the kidneys. So you could have, you could be assessing malignant lesions or benign cysts of the kidneys. So a lot of people have cysts in their kidneys as you age. But who was I with the other day? Tisha, I think it was, and they were scanning somebody and they had polycystic disease, and they were assessing for a kidney replacement, or they were trying to
renal transplant patient.
Yeah, a transplant patient. Thank you. That's what they're a transplant patient with polycystic kidney disease. So that's a very common reason you scan the kidneys specifically. Any other type of renal tumors, polynephritis, hematuria, blood in the urine, and kidney stones. So when you're looking at just the coronal kidneys, you can see you don't need to cover as much, but you just need to make sure you get A to P in front of the kidneys and behind the kidneys. And what's different about these coronals, you're going to angle with the kidneys and how they lay in the patient's body. So we know that the top of the kidney, superior border of the kidney, always sits a little bit more posterior than the inferior horn of the kidney. Axials are going to be basically perpendicular to what your coronals were set at. All right, adrenal glands. So very, very small glands. So if you have any hormonal imbalances, that could be caused by some issues with your adrenals. And these glands sit right on top of your kidneys. We talked about adrenal adenomas, so fat within, it's kind of like a benign fatty tumor within the adrenal glands. Other types of tumors and cancers within those adrenal glands. But you can see there's such small structures, you're probably going to do thin slices or 3D acquisitions to really visualize those small structures even better. So you can see here, we're just kind of angling the same as the kidneys, so we don't need to go through that too much. Indications for pancreas, acute or chronic pancreatitis. If you have anything going on with not only the pancreas, but the biliary tree, that could be a reason to kind of look at the pancreas. If you have stones within the pancreatic duct, tumor, cyst, staging a cancer. Pancreatic cancer has a high morbidity rate, so not many patients survive pancreatic cancer. And I think that's what Alex Trebek passed away from. It's a very low survival rate type cancer. But here I posted some images from Mri Master to help you visualize where the pancreas is a little bit better. So here's the head of the pancreas right here. And it always kind of Starts here, goes a little bit more anterior, and then the tail kind of goes more posterior. Here's the body of the pancreas, and then here's the tail of the pancreas. And the tail of the pancreas is actually more superior than the head of the pancreas. So here you can see the spleen for the tail, but then as you go down towards their feet and lower in the patient in terms of axial slices, you start to see the head of the pancreas. So you can see how the coronal slices are set up, but just make sure when you're getting coronal pancreas that it just starts here, it goes more anterior, and then it goes more posterior. So you might have to add more slices than you think to cover it all. Usually you can see that pancreatic duct splitting right through the middle of that pancreas. All right, moving on to MRA of the abdomen. So some indications, they're doing pre-surgical planning for stent graft, abdominal aortic aneurysm, AAA, evaluation of vasculitis, mesenteric ischemia, post-op surgical, renal artery stenosis, or aortic dissection. So that's a big one to make sure that if you see any type of aortic dissection, to notify your radiologist, because that could potentially be deadly within seconds. So that's MRA, but then MRV, we're looking at the vein. So portal vein assessment of liver transplant, portal hypertension, arteriovenous malformations, AVMs. A lot of these we've discussed in our pathology presentations before. So here is your MRA protocol for Emory. So these are typically kind of similar to your abdomen, but you're going to do a little bit more quick MRA imaging of those vessels, because you want to see the abdominal aortic branch off into the iliac arteries, and you want to see that filled with contrast. So this is what it looks like, and you can see the MRA, where all we're looking at is just the vasculature, because that's the flowing blood, so it's going to appear bright, and then all that stationary tissue is going to get saturated out and will appear dark. So anywhere where you have flowing blood, and the structures where you have arterial blood flow, like the kidneys, are going to appear a little bit brighter than your stationary tissues. So very pretty abdominal aorta branching off into the iliac arteries. So make sure you know these structures. And then this is the MIPPing of those structures, because they just kind of cleaned up all these extra tissues. They cut out, anything anterior and posterior so that you can see the MRA even better. So just, go in the notes, make sure you know all these structures for the test. So this is arterial. This here, you can see arterial and venous blood flow. So arterial blood flow is always going to be a little bit more midline, and then venous blood flow going back up the portal vein is going to be a little bit more to the patient's right, because their liver sits on the right side of the patient. So positioning for MRA, MRV, it's going to be an abdomen coil combined with a pelvic coil here, so that we can see that entire blood vessel branching down into the iliac arteries. Coverage here, just make sure you cover enough to get the abdominal aorta, but then you get the celiac trunk, the superior mesenteric artery, those renal arteries that branch off, and then your iliac arteries go a little bit more posterior than you think. So make sure you have the adequate coverage there. Sometimes you have to kind of just flip through all these axial slices to make sure you're not cutting anything off. All right, and then the last procedure we're going to talk about is enterography. So this is where you're actually going to have the patient drink some MR contrast called volumen. So indications for enterography, they're looking for low-grade small bowel obstruction, inflammation within the bowel, chronic diarrhea, ulcerative colitis, small bowel mass, and the main one is Crohn's disease. All right, so patient prep, you're going to have the patient drink 2 cups of the volumen. Usually it's timed out about an hour before the procedure. That volumen is just kind of like barium. It's, you know, it's a white contrast media, and it's, you know, very thick. Patients hate it. So they're going to drink that because that's going to coat their bowel. You're also going to inject glucagon, which this slows peristalsis. So glucagon is should be injected by your radiology RN because that is outside of our scope of practice. We do not inject. That's not a contrast medium. It's a medication to slow peristalsis. So it causes patients sometimes to get very nauseous. So you have to inject it very slow in a very small amount, but it helps slow peristalsis because we don't want to see those bowels contracting and relaxing. We want to see them just kind of without any motion so that we can better visualize them. And then we're also going to start an IV for gadolinium contrast because we're going to inject gadolinium too. The patient's going to lay on their belly to compress their bowel down, which eliminates the amount of slices you have to do, and it eliminates the respiration artifact. And so you're going to have the abdomen coil and the pelvic coil to get the entire bowel, because we need to get from basically the pubic symphysis up to where you have the hepatic and splenic flexures of the large bowel.
Is this the common exam? The one that you talked about?
Yeah, I mean, in places that you do abdomens, I know Winship does some of them. They've probably, I think they've changed their protocol around a little bit. Some places they're not having the patients drink the volumen anymore.
Main campus does them.
What's that?
Main campus, they do drinking studies.
Yep, main campus will do enterographies. I mean, anywhere where like you have inpatients with Crohn's disease, they'll do enterography is a good bunch. Outpatient procedures, not really. All right, so it says patient prep medication should not be stopped, I'm sorry. Should not eat MPO 4 to 6 hours or up to 8 hours. You should not drink any fluid for 4 to 6 hours. Water is allowed. But it's just talking about how the patient prep. It's like you're gonna basically drink, you know, the 2 cups of the volumen over the first hour. Typically a glass of water to follow that up right before the study. Make sure the patient goes to the bathroom. You're gonna inject the glucagon so that peristalsis comes to a halt or slows down. And then you hook them up to an IV for gadolinium. Okay, so here is the bowel with all that volumen contrast in it. And then here is 2 images where they gave the glucagon over here and they did not over here. And you can see that there's a lot of phase mismapping artifact on this image from the peristalsis. So here is your Emory protocol for MR enterography. And then this is just kind of the very specific prep. So volumen or Brisa, sometimes that's a different contrast. Over the first 20 minutes that they arrive, second bottle over the next 20 minutes, and then they usually give you either a 3rd bottle of volumen if they can handle it, or 450 cc's of water right before you scan. Levsin, which is a slows down peristalsis, or glucagon, depends on, you know, where you're at, but that slows peristalsis. And then you get them on the scanner, lay them on their belly to compress their bowel, and then run these sequences. So coronal, basically you're going to cover from the posterior to where the bowel is to anterior. So you don't need to get all through this subcutaneous fat because there's no bowel back here. And you'll be able to see the bowel very well because it'll be lit up with this contrast. So you'll know not, you know, where the coverage should be. And then you could do even Spinae imaging. So remember we talked about Spinae imaging. It's kind of real time looking at function and anatomy. So you do almost 1 Spinae slice, and then you basically copy all the parameters and move that slice a little bit anterior, do another Spinae slice, move anterior, do another Spinae slice all the way through the abdomen. And it's pretty cool because this is what the end result that you'll get. And just look at all the bowel. I think that's really pretty and cool. So that's the Spinae Enterography exam. All right. So the last bit of the PowerPoint is a bunch of pathology. I'm not going to go over that, but I want you to flip through these remaining slides so that you know it for the exam. But these are all the abdominal pathology that you might run into while you're scanning abdomen. So we'll end there. I know it's been a long day, but let me just go ahead and stop the recording here.